I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. Our topic for today is an update in gynecology. And I have one of the preeminent gynecologists on Staten Island with me here, a good friend, Dr. Kokkinakis, and pleasure to have you here today. And we're going to talk about gynecology, we're going to talk a little bit about obstetrics, and we're going to really talk about it during this COVID era, where things have changed a lot, and people, for a lot of reasons, haven't been going to their doctors as much, and seeing where we stand in this field. So, Simon, thank you so much for coming. And love to, just for everybody out there, again, different topics, what's a gynecologist?
Well, first of all, thank you for having me again. The gynecologist is the physician who takes care of women, is the best way to put it, and non-obstetrical issues with the female patients, ranging anywhere from preventative care to diagnosing malignancies, cancers, to treating a basic infection. So gynecologist is the doctor who takes care of a non-pregnant female. My best definition.
Tell me about your training. What kind of training do you have to be a gynecologist?
4 years of medical school after college, 4 years of a residency. The 4-year residency combines obstetrics and gynecology, and that's where you learn how to deliver the babies, operate, do surgeries, and take care of these conditions. And then you can specialize, or you can subspecialize. And the main subspecialties for for gynecology is reproductive endocrinology, which is the doctors taking care of infertility, and the gynecologic oncologists, the doctors that specialize in taking care of the cancers.
Tell me about COVID, where we've been 2 years, a little over 2 years into this. Tell me a little bit about how it's affected your practice. I mean, we've spoken before, and we actually had a television show about obstetrics, and you said pregnant women had to come to the office or had to be seen. Tell me about gynecology. And
the gynecologic patients, unfortunately, pushed their preventative care and their preventative visits. They pushed them out for about a year. Unfortunately, that means pushing their mammograms out a year. The pap smear, which is basically our way of detecting cervical cancer or cervical precancerous lesions. The new technology that we use today with the thin prep, as opposed to the old days when my Greek colleague, Dr. Papanikolaou, designed this.
The pap smear.
The pap smear. We use the liquid base now. So, that's good every 2 to 3 years, believe it or not. So, that was not the main issue, but pushing their pelvic exams, which is a way of detecting ovarian cancer. Unfortunately, it's difficult to detect ovarian cancer, but feeling for those ovaries in a pelvic exam, is the only thing we have. And their mammograms, which is the way of screening for a breast malignancy. I mean, those are the things that I saw being not neglected, but being postponed.
Have you seen complications because of that?
Some. There have been conditions that, if caught earlier, would have possibly not required surgery. Thank God, not many cancers. But there are things that occurred through the COVID era, and the patient needed a surgery that could have otherwise been a minor, possibly office procedure, especially with the cervix.
Have things gotten better now?
Things have gotten better, and they've been better for quite a while now, about a year. Once we were able to take patients back into the operating room, once we were able to see patients once again in the office, once the patient was comfortable, that was a big thing, patient being comfortable, coming to the office. So I think now with the vaccine rollout and more people being vaccinated, they feel more comfortable. And as our economy has opened up, I think patients feel more comfortable coming to the office.
I've seen that in my practice too as a neurologist. Patients are much more comfortable coming in. And a lot of things that we're just shocked, and the heart doctors, myself, we were seeing less patients with strokes during COVID, even though COVID did cause strokes, less people with heart attacks were coming into the hospital. And we really don't know whether people stayed home and succumbed and had major problems from these events, or for some reason the risks were lower because everybody was just at home. So we really did know, and we see that with GYN gynecology also, and that's what's really so interesting. Tell us a little bit about when someone needs to get to the gynecologist. So again, clearly this is a woman's issue, and maybe I'll even ask you first. Gynecology, when you think about it, is actually one of the primary care specialties.
Yes, yes it is.
There's pediatrics for kids, internal medicine for adults, some geriatrics for older patients. So when we don't sort of think about gynecologists as someone I'd go to if I have a cold, but when you talk about primary care, tell me how your relationship with your patients are.
You're absolutely right. A lot of my patients, especially my younger, healthier patients, probably don't have a primary care that they regularly visit, especially under 40. You know, a lot of times I act as their primary care physician. They tell me their concerns. They tell me if they're feeling depressed or anxious. They tell me if they have, you know, sniffles, or if they have a cough, or if they're not feeling right, you know, and many of those times I'll prescribe an antidepressive medicine. I'll prescribe an antibiotic, and patients feel comfortable doing that, and I feel comfortable taking care of them. I mean, a lot of these patients are also patients that I've delivered, so I have a long-standing relationship. So.
That's why we talk about your training. You're a physician who's done a lot of years of training.
Exactly.
And there are a lot of obstetricians. Interestingly, we have an overlap with patients who have migraine headaches. Younger women who have headaches, and many of the obstetricians are gynecologists, I use the term really, are very comfortable using some of the anti-migraine medicines that we use. And they come to many of my lectures, and it's sort of a very interesting dynamic between us with regard to it. So I enjoy very much working with the gynecologist. Sometimes when we deal with the obstetricians, we're dealing with more emergency situations. So it's nice to sometimes to be able to do things on a much more routine basis. So about what age should a woman go see a gynecologist? And does it matter if they're sexually active or not? And maybe tell us, because again, they're moms, dads, they're out there, and they're sort of saying to themselves, why, when would I take someone to a gynecologist? Is it something scary? Should they be ashamed of asking to go to a gynecologist if you're a young woman, if you're a teenager? And what do my parents have to know that, do they know that I'm sexually active if I go there? So give me some of the nuances, which I'm sure you know a lot more and see it every day.
Yeah, I mean, that's a hard question to answer. I think I'll start off with the easy part. A pelvic exam, pap smear, it is recommended that we start that at 21, regardless of sexual activity. So, you know, any woman out there at 21, regardless of sexual activity, you should come in for a pelvic exam. You should come in for a pap smear. Prior to that, I tell my patients when they ask me these questions in the office, I tell my patient, bring them in. You know, bring them in when you feel that they're ready to talk. A lot of moms, thank God, a lot of children, well, a lot of my patients' children, and you know, teenage children, they talk to their mothers, and then the mothers know when they're starting to be sexually active, when they're starting to be interested in the opposite, or you know, sex or the same sex. And I usually tell the patients, bring them in. I want them to know me. I want them I want to introduce myself to them. I want them to be able to come to me if there are any issues, as opposed to just Googling something. I want them to ask me questions about HPV. I want them to ask me questions about sexually transmitted diseases. I want to tell them what some of these complications can be. I want to tell them about safe sex when they are having sex. So I tell my patients at 21 they should start to have their exams. But prior to that, bring them in so they can be comfortable with me, because sometimes things happen and they're not comfortable going to mom. They should be able to go to the doctor and seek care. So that's my advice to my patients.
Tell them about picking a gynecologist. Some women want to go to a woman gynecologist. Some feel comfortable with either a woman or a man. Have you noticed that issue at all in Staten Island or in your practice since you've been out?
Very infrequently. Typically, women, there are women that want to go to a male gynecologist, and they go out and find a male gynecologist, and the other way around. But when we've introduced, at least patients that I've seen, when we've introduced female gynecologists into the practice, they're okay with seeing them in times of emergencies. So if there's something that needs to be dealt with, they're okay to see the gynecologist, male or female. But if they have a preference for a male, they'll go for their routine visits with the male. And if they prefer the female, they'll seek a female practice for the emergencies. But for the non-emergency preventative visits. But for the emergencies, I haven't really seen that patients that it really matters. I think they just want to get taken care of.
And you work in a major institution in Staten
Yes.
Island and part of New York City, big hospital. So, I mean, the structures and the safety that patients are sometimes concerned about, who's in the room when you examine a patient?
I think a chaperone should be in the room when anyone examines a patient, especially in that situation. I mean, we do very personal exams, and it's important that there's someone there to make the patient feel comfortable. I'm not going to say supervise the doctor. I think the patient feels comfortable when there's someone there other than the physician. I remember one time in the office, a patient started telling me about a previous gynecologist. She said he never had a chaperone, and it just felt that he was enjoying it too much. And when I hear things like that, I realize how important it is to just have someone in the room to make that patient feel comfortable and make that doctor feel comfortable. So we always have a chaperone when it comes to an exam, a pelvic exam, a breast exam. But just to talk during a consultation, I could do that on my own.
When you start talking about breast exams, tell me a little bit about the need for mammograms and just give everybody some guidance. I mean, sometimes the gynecologist absolutely does a tremendous amount of work with breast evaluation, cancer detection, and it's not just for reproductive organs. So tell me a little bit about what you look for and what do you recommend for our population. Our viewing public, we're all sitting there watching us and sort of saying to themselves, how often do I get a mammogram? I've seen some controversial issues. When do I stop getting a mammogram? Do I do self-examinations? Maybe give us a little bit of what the recommendations are.
I typically tell my patients to start having their screening mammograms at 40. That's a recommendation. Most agencies think I'd agree on that. Start at 40 and go yearly. And we're talking about women that are at a normal risk for breast cancer. Women that are at a higher risk for breast cancer typically start much earlier.
And how would you know if you're at a higher risk?
Well, we usually we have the patients fill out a questionnaire. We ask about their family history. We ask about first-degree relatives that have had breast cancer, especially a first-degree relative that's been diagnosed early on with breast cancer. We want to know that, because then our preventative plan is to start mammogram screening 10 years prior to the first-degree relative being diagnosed. So if mom got diagnosed at 45, we want to start daughter at 35, 40, 30. So we take a complete family history, and then a patient that has normal risk for breast cancer, we recommend 40. We start our yearly mammogram screenings at 40, and the recommendation is to go to 65 years old. Or 70. I've seen various agencies recommend different things, but I think the consensus is 65 to 70 years of age. If everything's been normal prior to that, it's probably safe to stop. I still recommend self-exams. I've heard I've seen some reports that evidence doesn't support that. Evidence has not shown that it's picked up, more cancers than if you're just getting your yearly your yearly exams from the doctor. But I still think it's a good idea to have your monthly self-exams. It's good to if you feel something that shouldn't be there, if you feel something that wasn't there last month, you have to bring it to the physician's attention, and then we can examine the patient and get the appropriate imaging.
You mentioned HPV before, and that's really a somewhat hot topic in medicine. Tell us what human papillomavirus or HPV, tell us about the inoculation, the vaccine, and who should get it, and really how important is it?
HPV is very popular. HPV is very common nowadays. It's an STD. It's the human papillomavirus. There's many types. The ones that can potentially cause cancer are considered the high-risk HPVs. There are some that are higher risk than others, namely type 16 and 18 are probably the highest risk for cervical cancer. But again, the risk is still low, but they're the higher of the types. And then there's the low risk HPVs, which we really don't look for, and they're the ones that cause genital warts. So with HPV, the problem is women become infected. Their bodies do a good job, especially the young and healthy patients. Their bodies do a great job to keep it undetectable. Their immune system keeps it undetectable, and when it's undetectable, it's not causing injury to the cervical cells. We call that dysplasia. So when patients have HPV, we're trying to diagnose dysplasia and deal with that. So we had a vaccine. It covered 4 of the HPVs, and that was the Gardasil. Now we have the Gardasil 9, which covers 9 types of HPV, and that's big. Getting that vaccine to cover more types was great to see. It is recommended to start at 9 years old. It's typically a 3-course vaccine, and early on when we had Gardasil, it went to 26, but now they've recommended it to even patients up to 45.
So if you've had the old Gardasil, should our patients get the updated type?
I think you should. It's very important because you're getting protection from more types. And remember, it's not just for women. It's also the recommendation is for boys and girls to get the vaccine early on. When they're young, they're going to mount a great immune response to the vaccine and hopefully be protected. And when they are getting sexually, the key is to get vaccinated before you're exposed to it, meaning before you're sexually active. And then we can see a big reduction in these, precancerous cervical lesions and hopefully cancer. Luckily, we don't see a lot of cervical cancer in the United States. It's more prevalent in third world countries, but it'd be nice to see even less.
Gynecologists are obviously surgeons, because gynecological oncology
Absolutely.
and other things that are taken care of. So tell me a little bit about new techniques. We know about laparoscopic, robotic techniques in sort of the general surgery world. Has it caught up, and has gynecological surgery really been on the cutting edge with these less invasive procedures?
Yeah. I think we've the days of doing open cases, meaning making cesarean style fan and steel incisions on the abdomen, midline incisions on the abdomen, to remove the uterus, to do a hysterectomy, to deal with things, is I'm not going to say over, but it's not very prevalent anymore. The majority of our surgeries are done laparoscopic. Laparoscopic is minimally invasive. Little, half-inch incisions, 1 in your belly button, 2 on your right above your hip bones, and they're typically the size of my finger, and patients do great. They heal well. So that we're doing robotic surgery now in gynecology. Robotic surgery has come a long way. I think it's going to get better. There's a lot of equipment, and it just takes a lot of time to set up. Once everything is set up, it's a very nice it's a laparoscopic process. It's just another way of doing it laparoscopically. With the robot, it's very safe. It's very, I think certain cases warrant the robot. Others probably, can go the regular laparoscopic route. But anything the surgeons are doing, I mean, we are utilizing the same equipment, and we're right there neck and neck with them.
So working in a large office, working in a large hospital at Richmond University, you always hear the word D&C. There are women going for D&Cs, and sometimes it has, maybe when the women speak to each other or others, there's sort of an idea, what is a D&C, and how long is someone out when they have a D&C, and how major of a procedure it is, and why do they do it?
Yeah, I've heard that as well. DNC,
Well, you're a gynecologist, so
I hear it a lot. DNC is a dilation and a curettage. In layman's terms, and I hear this all the time, a scraping. It's basically scraping the inside lining of the uterus, the endometrium, and basically we do the dilation and curettage. So the dilation part is the act of opening up the cervix, because the cervix is imagine the cervix is the cork on a bottle of wine. Imagine a bottle of wine. It's a cork, and you have to dilate that and open it up in order to get into the uterus. So dilation of the cervix happens, hence the D, and the curettage is the scraping of the cervix, which is the C. We do it for patients menopausal patients, and they bleed unexpectedly, postmenopausal bleeding. We do it to sample the endometrium, many times to look for cancer, sometimes to look for precancer. Sometimes we do it to remove a polyp. So that's in the gynecologic world, that's what a DNC really accomplishes. Obstetrically, when a person miscarries, we do a DNC to remove the miscarriage, the pregnancy that's not viable. Again, the D to dilate the uterus, the cervix, and then the curette. And in a miscarriage, we use a suction curette to remove the non-viable pregnancy. Those are the two main reasons you hear the term DNC a lot. We do it a lot.
We do it. It sounds that way. So let's go into something that people are always talking about, and that's fertility treatments. So reproductive endocrinology, where hormones are given, and I see so many patients in my practice getting headaches sometimes when they get it. Wow. They feel a little different. And clearly hormones have a lot to do with a woman's behavior, neurological status, medical status, and of course what you guys are doing. So tell me, where have we come with fertility? Do a vast majority of patients who are younger actually are able to have a baby with in vitro and all these things? I want to take some of that mystery out of it. The idea of test tubes, and when I was growing up, they would have doing a test tube, what's going on. And now it seems so much more commonplace, and patients are doing so much better, and a lot of our older patients are having children. So tell us about fertility issues and what you see in the office.
We've come a long way with fertility. These reproductive endocrinologists, these specialists, they can get many people pregnant, various ages too. Typically in the office, a patient will come to me and the main thing is to tell me that she's been trying to get pregnant, and she's been trying for a year and she hasn't been able to. And as a gynecologist, I would start the workup to see if there's a reason for this. 80% of the time, there is no reason. 80% of the time, it's just an unknown thing that's happening.
So it's not his fault, her fault.
It's not his fault. It's not her fault. It's just not happening. 10% of the time, it's a female factor. It's the ovary may not be producing eggs, or the eggs may not be of good quality. Sometimes the tubes can be blocked. That's also a female factor. It could be 10% of the time. It could be a male factor, and that's typically the semen. The sperm count is not where it should be, or the motility isn't where it should be. So we would start the workup when it comes to that. We would send the partner for a semen analysis. The patient would go for some blood work to assess the health of her ovaries and her eggs, and we would test the patency of the tubes, and then go from there. You know, a lot of times we refer to the infertility doctors. They could do various things. They could do in vitro, which means taking the stimulating the ovaries to make follicles. Follicles contain the egg. They go in with the ultrasound. They remove the egg, and then they put the egg with the sperm and watch the embryos develop, and then you know, put the best grade embryos in. Sometimes they freeze the embryos, test them, and put them in at a later time. Sometimes it's as easy as giving the patient some clomiphene citrate, you know, which basically tricks the body into thinking, you know, there's not enough estrogen, and then you trick the body into thinking there's not enough estrogen. The brain makes more FSH to tell the ovaries make more estrogen, hence more follicle production, and then you induce ovulation, and when the eggs are mature, when the follicles are mature, and sometimes that's all it takes. So with these techniques, we're able to get patients pregnant, and with the general gynecologist being able to start the process, you know, it helps a lot of women, because not every insurance plan covers advanced infertility, and patients really can't get the help that a lot of times they need. So with the general gynecologist, the generalist, starting the process, we provide a big service to the community, and hopefully bring
So a certain
happiness.
percentage will become pregnant by
Sure.
going there to the gynecologist.
Absolutely, because the majority, you know, require a little bit of Clomid because it's unknown. But when you do find the male factors or the female factors, or if you do find the patient that's a little older, you know, these are the patients that really should be referred to the reproductive endocrinologist.
At what age do you think?
You know, 35, above 35 is advanced maternal age. I think patients that are having difficulty above the age of 35, or that have true, you know, fallopian tube problems, or their ovaries are not, or their ovarian reserve is not optimal. These are patients that are not getting better, you know, as the months pass. They should really go to an endocrinologist if they're serious about getting pregnant, and start the process. I mean, I don't want to waste their time and then have to refer them. So, you know, under the age of 35, it's reasonable to have the general gynecologist start the process. After the age of 35, when time is of the essence, I think they really should go to the specialist and you know, get the more advanced treatment to get pregnant.
I want to say thank you for coming. I'm actually going to give you a couple of seconds. To the women who are afraid of going to the gynecologist, and there are some, what would you say to them about coming? And as I said, I see too many, maybe my patients are a little different than others. My staff, they roll their eyes. They don't want to go to the gynecologist this year. Tell me about just what could we say to them to really convince them how important it is?
I think preventative medicine is very important. Screening for cancers of the cervix, of the breast, is very important, and and these are cancers that are preventable. Don't look at Google. Don't Google things, is my advice. You know, every doctor, every gynecologist is different.
I'm going to interrupt you because we're really coming to the end.
Okay.
I want to say thank you for being with us and teaching us all about gynecology.
Thank you.
Good night, everyone.
Good night.
Sorry.